I'm going to give a little pep talk first as to why academic trainees ought to care about this field, because I think that's probably important. Some of you probably don't care and you're just here because the sandwiches are good. And the only reason I put my titles on this slide is not that I think it's important. In fact, I teach at Harvard College, and the only way you can fail my general education course is to call me doctor or professor. So, my name is Don, and I do put these titles up there just to give you hope, because I do clinical research and a lot of quality improvement, and somehow I got to be a professor. So first, we say that it's quality improvement, not quality assurance, and it's not about punishment and reward. That's a tough message because, as you probably know, pay for performance, physician profiling, all that stuff is really in play. So, like it or not, there is that component to it, and I just try and be upfront about it. Some of my colleagues are really gung-ho about quality improvement, and they talk about it like it's some religion from the East, and I don't do that. I'm probably not going to talk much about Toyota today, and I probably won't talk much about the great founders of quality improvement from industry. So that's another mistake we make. We tend to focus on non-clinical processes and outcomes like waiting times and patient satisfaction, and they're really important. But let's say you want to get a urologist. Anybody here? No, you can't be a urologist. This is not that program. But let's say you're a urologist, and I came up to you and I said, okay, we're going to talk about quality improvement, and what we're going to talk about today is the waiting times in your clinic. And your specialty is doing resections of the prostate for cancer. And probably what you care about more, what would be more engaging to you, is talk about what you want for your patients, which is that they don't leak urine, they can have sex, and that they don't have recurrent cancer. And if you bring that dialogue, you'll probably be better off. Trying to do QI by the book is problematic. You guys have a soft life in your particular specialty. You don't have to get up at 5 in the morning to go to the OR, right? You may get up at 5 in the morning anyway, but if I want a surgeon to talk to me about the systems diagram that I want to build on doing urological surgery, I'd better come to the OR at about 6 in the morning to catch the surgeon there, and not invite the surgeon to an 11 a.m. Meeting to talk about quality improvement and how to do a system diagram. We're not upfront very often about the fiscal agenda. A typical thing is quality is free, quality saves money. Actually, quality takes a lot of time and resource and effort and has a real cost associated with it. So I'm always really clear about what's the fiscal agenda, what the resources are, how much time it takes. I think that actually helps a lot. We don't provide people with the data they need. So, okay, I'm going to pick on somebody, and there's no embarrassment here, but who's not got their mouth full? Clever. So, you introduced me. So, what are the quality and safety strategic priorities for BMC now?
That's a great question. Reducing, it depends which department, but reducing mortality, wait times, discharge times.
Okay, where would you go to get that? You're working on that because you want to be aligned with the hospital, and so where would you go to see the data for the last 5 months on any of those?
Somewhere on the website.
Right. So, exactly. And you can imagine if you want to work on something like asthma readmissions, and you're really working hard on that, you'd actually like to know probably month to month how you were doing, and you'd probably like to know for your clinic. And I'm guessing that that's going to be hard to do. I found one hospital that I think is actually doing it well, and that's CHOP. We had some folks from CHOP up, and they are really working on one keystroke away for things that matter to clinical folks, what they're likely to be working on. And then we don't emphasize the academic potential, and that's a lot of what I'm going to be doing today is talking about that. There's an unhelpful siloing between the clinical researchers who do quality improvement and traditional health services researchers. Don Berwick keeps telling me that there's this he's even publishes about this uncivil dialogue between health services researchers and so-called improvement scientists. And to some extent that's true. I went to visit a very prestigious academic medical center in British Columbia, actually in Vancouver. And there was this wonderful research establishment that had all the things you'd ever want: behavioral, sociology, statistics, you name it. And they had never been asked to come to the wards to help people with their quality improvement projects. And the people in the wards didn't know they existed. And that's pretty frustrating when you've got all that firepower and you're not using it. And I've seen the same things in the US, but there are reasons for optimism. I'm on the board of trustees of Academy Health, which is the main academic health services research professional organization in the country. And quality improvement is all over their agenda. It's going to be in Minneapolis. There'll probably be 5 separate oral sessions and a lot of posters on quality. If you go to the Society for Hospital Medicine, you'll find several hundred abstracts being submitted in quality improvement. So I think that's good. But what's really impressive to me, I was down at Penn. They had a strategy day for how to get what we're talking about into practice at all of Penn's programs, including CHOP. And the chief of cardiology was there. And I went up to him, somebody said, it's the chief of cardiology. I said, so why are you at this talk, which is similar to what I'm talking about today, actually? And he said, because 5 or 10 years ago, and they have a very competitive program, 5 or 10 years ago, we might interview or get applications from 90 people, and none of them mentioned quality as anything they were interested in. And now there's a whole bunch of them, and they're good people, who say that they want to make quality improvement part of their career. And if I don't make it easy for them to do their work and get advanced, I'm going to not get the best candidates anymore. So there's this kind of change that's occurring that's very, I'm kind of optimistic about it. One of the things we need to do is to make progress towards aligning the quality and safety work that residents and students are now required to do with what the hospital wants you to do as part of their strategy. That's why I asked the question, do you know the strategic goals of the organization? How aligned are you? So we'll talk a little bit about that. It's actually really urgent that we get this right. You all know about CLEAR, right? Is there anybody, it's, again, no, don't be embarrassed if you've never heard of it, but how many people don't know what CLEAR is? So they've beaten it into you. It's like the Joint Commission, right? They're coming, but it's supposed to be a learning experience, and they really mean that. They're coming to have a dialogue about how aligned your quality and safety work is and how competent you're really becoming, and that sounds really great, except we all know that someday these are going to be standards that they will come around and check as accreditation standards. And there's a lot of reason to believe this is going to happen because MedPAC, which advises Medicare, has already stated that part of general medical education reform is to shift payment away from a gift to a pay for performance. You have to be able to show that the residents are actually learning quality improvement and applying it in their work, and that it's real work and not just they show up in a morbidity and mortality conference. So that's coming. And then there was an Institute of Medicine report that was really very, very good. Has anybody read that? It was by Don Berwick and Gail Walensky, and it was the future of general medical education, how we ought to pay for it. And what they basically said was that the days of giving a gift to partners or the MGH or whatever to train residents, the amount is now some very large amount. I think it's, does anybody know, it's $130,000 per resident per year, some very large amount. And that, trust me, goes straight to the bottom line of the hospital, and then they figure out how they're actually going to spend it. And there are a lot of nuances to it. There's caps, there's this. Basically, though, it's no accountability. Here's that the quality of your training be linked to how much money is given, and it's not a zero-sum game. Right. And if you're a CFO in an organization or head of the training program, to you it looks like a loss because you don't know if you're going to get that innovation money or who's going to get it or what it even is. They also talk about training doctors for the future, and a lot of this has to do with meeting the so-called triple aim. Are you all familiar with that? So it's the simultaneous effort to optimize patient outcomes and experience with per capita cost of patient care with population health. And that's frankly really difficult to achieve. IHI's been working on the triple aim for 8 years. We don't have a single peer-reviewed paper yet on results of an organization that's actually improved on the whole triple aim, and a measurement framework for how we know that residents are getting competent in triple aim practice and thinking. We can't even get you in the primary care clinics on a consistent basis so you can do quality improvement in primary care, let alone in the community. So there's some bright spots, but in general it's a long way to go. But that's where we're going. And we're seeing now these core competencies in medical school and residency training, and then it's part of maintenance certification for you when you become, when you're actually practicing. So things are aligned longitudinally, but in fact how we measure this and how we pay for it is really up for grabs. We did a 90-day innovation project at IHI. We tend to take some thorny problem and spend 90 days trying to find innovations and test those innovations. And what we were trying to find were programs that were aligned, where there's a shared understanding of what the strategic aims are for quality and safety with the organization and with the house staff. And we were trying to find organizations that actually were able to execute on that shared agenda and had a capable house staff who could really do it, and a capable faculty that could lead it, the latter being very difficult. And what we found was a lot of deeply entrenched barriers, so always a disconnect. There are almost no organizations where the head of the residency training program and the residents can articulate the goals of the organization, and where people in the C-suite, like the CQO, Chief Quality Officer, Chief Nursing Officer, actually know what you're doing. They know you're doing some projects, and they show up at some celebratory day. Do you have a celebratory day? You know, and they show up and they give a speech and they pat you on the head. I mean, they really don't know how what you're doing helps meet their goals. In fact, they disregard you by and large as improvers. They see you as a pain in the neck, right? You do a lot of testing and waste a lot of money because you're learning. You make a lot of mistakes. I've written some of the things that they say about you, as opposed to looking at you as a workforce that can really accelerate their ability to meet these aims if properly aligned, trained, and given the time and resources to do it. And then a lot of what we do, obviously, is kind of little things, like we go to M&M or we have a little project. There's scheduling nightmares if we want to do interprofessional quality improvement, getting nurses and physicians and pharmacists and really together, let alone microbiologists. It is really, really hard on a consistent basis. Your episodic rotations are almost lethal. So you tend to do these projects. I don't know what you're doing. Is anybody doing a project? What are you doing?
I'm doing a project to improve care for new immigrant patients at my primary care clinic site.
Okay, and
they're longitudinally, so it makes it a little bit easier.
And you're doing it throughout the whole year? Mm-hmm. So that's great. Of course, you're an exemplary institution, right? Isn't Moses here and all that? Yeah. So I mean, you're probably an exemplary institution, but it's hard. It's actually hard to do it, I'm sure, and you're probably doing it as well as anybody. So. I don't want to hear a lot about the committee, the quality committee, and the chief resident of quality. I want to hear about projects like that. And you have your data on a run chart, right? And you could show it to me now? Because your mouth is full. But you do, right? Yeah, good. There are other barriers here, especially around the interprofessional learning. It's really hard to get improvement expertise rushed to the front line when you need it. You usually have to call the quality improvement department and make an appointment. Maybe somebody shows up or not. There are very few faculty who are trained in point of care experiential learning in an interprofessional environment, and there's a tortuous promotion pathway when you get out of your training and fellowship. We did a driver diagram because you're supposed to do that in quality improvement. These are the main drivers to producing qualified, capable, engaged, and motivated faculty who can actually teach you and support your work. And I'm not going to go into this in any great length except to show you this career pathway here, where you need a true professional pathway with metrics for getting promoted. You need mentors. You need to get some respect and prestige. You need some financial incentives. You need early career training and so forth. And I just put this up there to show you that we've thought a lot about what all the drivers and changes are that would need to be done to have a successful program where faculty were rewarded and able to give you some help. So let's focus on the career pathway. How can a young, motivated improver achieve academic credibility? And here's where, whoops, sorry. And these are the key attributes of quality improvement or scientific quality improvement as I see it. So I'm just going to go over them, not that you don't know these, but you ought to be able to articulate what scientific quality improvement is in 5 minutes if you have somebody's attention in the hall. And I've been practicing on doing this in 5 minutes. So if somebody wants to time me and see if I'm getting close to goal, that would be great. First, you need a clear, measurable aim. So the clear, measurable aim on your improvement project is what?
It's improving adherence to infection control measures in the ICU by end of May.
By how much?
Oh gosh, I think it's 20%.
Yeah, okay, so that's good. That is a clear, measurable aim. And then you need a measurement framework in support of reaching that aim. And so your measurement framework has some process measures probably, right? You have a driver diagram or some sort of plan, and you got an outcome measure, and then you have process measures, and you know what you need to measure, right? So that's pretty simple. It needs a clear description of the ideas or the content that you expect to impact on the results. This won't be 5 minutes because I'm asking questions. So if you want to reduce central line associated bloodstream infections, which is easy pickings, right? So what would the theory be for the content or ideas that you have that are going to reduce CLABSIs?
Can I interrupt you?
Yeah.
It's actually not easy pickings here because we have almost no central line infection.
You have none?
We have, it's very low.
Well, that's good. That's why it's easy pickings. It's really easy to do. Okay. How about, do you want to take, what you name a problem that you think?
So my project is better control of hypoglycemia in the intensive care unit.
Okay, so what's your content theory? What are your specific process measures and changes?
So the end outcome that we're looking for is institution of an insulin drip when they meet criteria, which is essentially severe septic shock in the ICU.
So that your outcome is a process measure?
It's a process measure, because the actual control of blood sugars, we narrowed it in, basically. I know.
No, there's no need to apologize. So you have a theory that if you do, what is it again?
If we control blood sugars within the acceptable ranges in the
Right.
ICU, not the night sugar data or anything like that, if we control it, then our outcomes will be better, because big picture surviving sepsis says if you maintain adequate blood sugar control in severe sepsis, septic shock, you'll get better outcomes.
Okay.
We're not measuring
So-
outcomes, we're measuring.
So your theory is if you can get better without causing hypoglycemia, right, and having people seize and get brain dead, that you will improve mortality in sepsis? Is that it?
Ultimately, yeah.
Okay, and the attributable effect on mortality of getting it perfect, if you got it as good as you think you can possibly get, and I don't know what your goal is, and you reliably did all the things that are required to get to that level all of the time, 100% of the time, what percentage of the total things you need to do to reduce mortality would that represent? In other words, what would the attributable effect be?
It's not that high.
So,
I don't know, 10%.
okay, so what I'm trying to say here is that there is a theory and a prediction, and it's a mathematical thing. And I almost never see somebody who's actually put on a piece of paper what the attributable effect is with the confidence intervals. In other words, what is the degree of belief that by making these changes you will improve the outcome by X amount? So if I say, for example, and this is now obviously more than 5 minutes, we may not get to the talk, but it's interactive, that's good, right? I have a theory that if I'm interactive, you'll like me better. So let's say shaving for surgery in adults. If you went in for a hernia repair, nobody, I hope, would use a razor to shave your hair, right? They would think that that would increase the chance of bacteria and infection. And countless people around the country are doing this, which is a good thing. The attributable effect, I think, based on what I know, is probably about 2%. So the trouble is you do these things and you haven't accounted for all the other things, you're not working on them, the outcome doesn't move and people lose hope. But if you're explicit about it and say, I don't expect the outcome to move to do this, these are the other things we'll have to do. And by the way, 50% of the effect is unknown and unmeasured. And that's always, so we always tend to exaggerate the impact of our very important improvement work. And that's the content theory. Then we have a clear description of the implementation strategy, or we have this horrible word, execution theory. I don't like that word. Somebody tried to use it in Saudi Arabia and talk about the execution theory, and it didn't go over very well. But this is, what are you going to do to get reliable implementation of whatever it is you think is going to keep the blood sugar where it needs to be. And that's often confused with the content theory, and it's a separate thing. These are activities, behavior change techniques, leadership, teaching, you name it, that you think are going to get people to actually act differently. Got it? So content theory and implementation theory. Then there's a dedication to rapid testing, which you all know about, I think, PDSA cycles, understanding the system, which, by the way, a systems diagram is very similar to a value stream map in Lean. So I don't know if you use Lean or Six Sigma, but the principles are the same. And then you want to learn from variation, and you've heard this a lot, right? If you had any quality improvement training at all, people say, we want to look at variation over time. That's why we plot our data in a time-ordered way. We do run charts, we do statistical process control charts, because there's a relationship between those run chart rules and the statistical process control and the kind of frequentist statistics we all probably learned in high school or medical school, maybe you learned it. So they are real statistical techniques designed to say, is this change random noise or is it a statistically significant effect? So that's important. But there's another kind of variation, and that's variation among residents, among wards, among programs, among states, among countries, that is equally important to learn from. And unfortunately, most clinical trials and most studies you see in the literature aggregate the findings and adjust away all of the heterogeneity, because health services researchers regard those things as nuisance, confounders, distortions, whatever, of what they're trying to portray. So you can't find the heterogeneity. So here's an example. There was recently a study in the New England Journal of Medicine on medical homes in Pennsylvania that you may have seen. Anybody see that study? It basically was done by people at RAND, Eric Schneider, really good people, and the impact of medical homes on a number of outcomes of interest, like diabetes management and blood pressure control, was zip. That was the aggregate result. And so people in the improvement community went absolutely bananas about this. I mean, it was vile. Hearing, and these are respected people, hearing them trash really good researchers who were asked to do a quantitative analysis was just disheartening, because I said, well, maybe Don Berwick's right. Maybe we'll never have civil dialogue. And I pushed back and I said, so it's great. I know you would like to see how all the clinics did and whether there were any stars, so you can learn from the stars, and whether the rest of them failed because they didn't understand who Deming was. That's really important to know. But what makes you think that that wasn't done? You're trashing these authors who were asked to do a specific thing. Maybe somebody did this other work. Maybe somebody did qualitative analysis, and it turns out they did. And there was a paper, they actually described it as positive deviance. What was it that led some medical homes to actually perform very well on these metrics? And they published in another journal. So you have to be generous and make these inquiries. But in the main paper, it's almost never there. For example, if you're doing a large randomized controlled trial of a new drug for hypertension, usually it's now in 22 countries and 103 sites, and then you publish your results showing that the blood pressure medication was effective in reducing blood pressure, it might be that in Spain, it didn't work at all. And nobody ever talks about that. Nobody ever says, well, it worked someplace, it didn't work other. Why didn't it work in Spain? Well, maybe they're using it differently than the protocol actually said, or maybe people of Mediterranean extraction don't respond. We know, for example, that African Americans don't respond as well to certain blood pressure medications. You have to be curious to find these anomalies. Anyway, so that's what I mean by heterogeneity. And then, of course, using behavioral and social sciences, which isn't well done by improvers. Behavioral economics almost never used in improvement, just as one example. So when I talk about quality improvement, I always talk about this as the experimental method. I think it's a mistake to talk about it as something that's a different science, improvement science, as opposed to the experimental method. So I spent 10 years working with a PhD scientist trying to develop a staph vaccine. And let me tell you why I think we did quality improvement. So we had a theory. We had a theory that if you extracted something called PNAG, which is an antigen from the cell wall of Staphylococcus, and we injected it into people, that they would make antibodies that would be opsonic and kill Staphylococcus and reduce the risk of infection. That was our theory. It's a content theory. We think that this antigen will produce opsonic antibody that will kill staph, and it will work in people. So what did we do? We said, okay, well, we can't just start injecting people, so we got some rats. And we said, well, why don't we try taking this antigen and putting it in the rat at such and such dose subcutaneously and measuring to see if they get any antibody response at all, let alone opsonic. And lo and behold, we did that, and there was no response. That was a PDSA cycle. And what did we do? So we planned the experiment, we did it, we studied the result, and then we changed the dose. And when it still didn't work, we changed the route of administration to intramuscular. And we did this and did this and did this. And people say, well, that's rats. That's not like working on whatever wards you got here, 9 North, right? There it's complicated, right? We have complex systems. And so you have to use some special science for that. It's not the experimental method, it's improvement science. And so actually, the laboratory in which we were doing these experiments is more complicated than you think. First of all, not all rats are the same. You have to decide whether you want Sprague-Dawley rats or some other rats, germ-free rats or non-germ-free rats. You have to decide whether you're getting from Charles River or somebody else, because believe it or not, it matters. And then the temperature and the noise and the cleanliness of the cages all matters. The gentleness of the animal handler matters. And actually, the culture in the lab matters. So the guy who ran this lab, he's a really good friend, but he's a bit of a, he tells jokes that I think are inappropriate that include women. Let's just put it that way. And of course, most of the people working in this laboratory are women, and I don't think that's accidental. I actually think there's a gender bias in the laboratory. So that's a cultural phenomenon that is occurring in that laboratory. And then he kind of doesn't really listen well, and he's a little bit dictatorial. And so if you were to do a culture of safety survey in that laboratory, I'll bet that people would say they were reluctant to speak up or differ in their opinion. And I bet they'd say that they didn't feel safe psychologically in some ways. So, you know, I actually think that if you just talk to people about this being an experimental method and then elaborate, you do a lot better than saying improvement science is not the same as working at the bench, because I think it is. The other thing that is interesting, Timmy Ho, who's an neonatologist and is a fellow at IHI and also at Children's and Health Services Research, made an important observation. What he wanted to think about what we could learn from lab science. So I'll pick on you again. So do you record every PDSA test you do and what happened in some binder?
Yeah, sort of, yeah. A bunch of sheets of paper.
A bunch of sheets of paper. How do you store them?
In an office, in a box.
In a box, yeah. So that's better than not recording them at all. But I've actually looked at studies of PDSA cycles, and we've done many, many, many projects at IHI. Getting the description of what happened in that PDSA cycle is almost impossible. They may start and do a few, but basically at the end of the project, if I ask, so tell me about the contextual factors that influenced your improvement so that you changed your approach. Show me that data. They say, well, oh, when did we do that? I don't really remember. And then they may produce from their data, oh, gosh, we weren't as good at recording these as we thought we were, right? So that's a problem for Timmy Ho. And it turned out, that when I thought about it, it's a problem, period. Because in the lab, very busy people who are trying to do their thesis or trying to get a grant and are working at 4 in the morning to make sure the animals were fed, keep a lab book in a real binder, not a something where you take the pages out. And that's their record. And that's why we now know, for example, where the fraud is. People can't reproduce the results. There is a lab book. We don't think we're too good to have a lab book in improvement. It's too complicated, so we don't keep a lab book. And I think that's not right. People say, well, we don't have the time. We're not paid to do it. All right, well, whatever. But, you know, the only people in the world who are working hard aren't people who are doing quality improvement. I'm being tough, aren't I? Harsh. Sorry about that. So I'm going to now spend some time, probably about 20 minutes, just going through some projects to show you that rigorous publishable quality improvement can be done anywhere without federal grants. I have a very long CV, and none of the quality improvement projects, and there are probably 20, 30, 40, were sponsored by a federal grant with one exception. Which I'm not going to discuss. It was a big NIAID grant, but everything else, no federal grant. So here's my first quality improvement project that got published. And I don't want this to sound arrogant. I'll try and tell you what I think the key principles are, and they're not about being particularly smart or working harder than the next person. So this was to see whether or not a standard antibiotic order form would reduce the inappropriate use of antibiotics in surgery. And just for simplicity, the main goal really was not to deal with empiric antibiotics for an infection or the actual drug that was chosen to treat an infection. We want to focus on prophylaxis. At that time, the new data said that you can give prophylaxis, should give prophylaxis for 48 hours for surgery, and that was enough. Now, I know now we give 1 dose, but when we did the study, it was actually 48 hours or maybe 24. And you can see the sort of, I don't know what color that is, turquoise bars, that the average was about 5 or 4.5 days, and a lot of people were getting 6 and 7. So clearly not practicing by the evidence. So Jerry Durbin, who is an infectious disease fellow and a pharmacist, decided, well, let's try something. And so we did what, to my knowledge, the first standardized order set. And it was on paper, we didn't have computers. And it had 3 pieces. One was prophylaxis, empiric, and then treatment. And in the prophylaxis box, it was 48 hours, and then we stop it. And there were obviously safeguards put in when we were at first doing this. But the trick was that any physician could override that simply by writing the reason. And one surgeon was an orthopedic surgeon, and he said, I take care of osteosarcoma. No way am I given that short course for kids with osteosarcoma, you know, Kennedy's kid or whatever. I'm just not doing it. I said, fine. I'm not going to sit here arguing with you. Let's have a cup of coffee. I want to understand. And so he wrote 7 days of antibiotics for every one of his patients. And that's fine. And you can see, actually, that little red bar at 7 days was his patients and a couple of other surgeons who thought a week is a week. In general, the curve shifted, and never mind that there's some that are a little more than 48 hours. That's due to the way the record's set up and so forth. But basically, the vast majority of people got 48 hours or less. And this got published in JAMA, which is hard to do. I mean, people say, Don Berwick said, you'll never get published in the New England Journal, or you just, and this was back in 1981, and it was a resident, a fellow, and a pharmacist, and me on the sideline. Oh, by the way, that's a terrible, terrible graph, right? You know, so what's wrong with that graph? Do you see anything wrong with that graph? As an improvement scientist? There's no time-ordered data. It's a basically before-after study. That's awful. I mean, that's a really terrible thing. But I didn't know. I mean, I didn't even met Don Berwick, so that's the best I could do. It's also not a very good. I mean, it's hard to read. It's awful. Apologies. Sometimes you can do analyses that aren't statistical process control or whatever, and you collaborate with people. So we had a problem with RSV on the infant toddler ward. As you know, I'm sure, hundreds of kids show up every year with RSV, and they come on the ward and there's snot dripping down, and they're just, and you get sick and the other patients get sick. And in those days, the nosocomial infection rate was staggering. And so we wanted to do an experiment to see, could we bring this rate down and improve infection control? So a nurse, infection control person who was actually at that time a medical technologist doing infection control, myself, and a epidemiologist, Jonathan Freeman, did this study together, and because I didn't really get the statistics very well, and he was going to help me. So what does this show? This is on this axis is what we call the SNOT index. It's the percentage of babies on the ward who had RSV, and we didn't even bother culturing them because at that time of year, the vast majority of them had RSV. And this is the incidence density or the rate of nosocomial RSV per, 1,000 patient days. And at the beginning, we decided we're just going to do secret shopper monitoring. We're going to sneak around and observe and pretend to be doing other things. And we found that the compliance rate at that time, I think, was 37% with gown and glove precautions. Not very good. And then we did monitoring open. So everybody knew what we were doing, and the compliance rate, as I remember, went to 92%. And then the effect was so dramatic, as you're going to see on this graph, that we just went back to secret shopping, and the compliance rate was still around 88, 89%, because people could literally see the impact. And so here you are. Here's the low compliance period, and there is a relationship between the SNOT index and the rate of infection, dose response, as you would expect, right? So it's not very many data points, but it fits well to that line. Jonathan Freeman assured me that this was good. And then in the high compliance periods, there was still a relationship, but it's all tamped down. So in fact, the higher the exposure level, the bigger the impact of doing simple gown and glove precautions. So that's a different kind of statistical analysis. It's not the usual control chart, run chart, but it's very sound way to look at the impact of this intervention. Again, I hadn't met Don Berwick, and this got published in the New England Journal of Medicine. No money, just part of routine work. We did this study. I mean, obviously a little record keeping, but it wasn't like we ran around spending total gobs of time. People in their routine work, making rounds or coming on the ward for other reasons, just made some little notes about what they were observing. So what have you seen? What do these two papers have in common? One's about RSV, one's about antibiotics. They're both infections, that's in common. Different statistical methods, not using scientific improvement methods. But there's something in common in the authorships. And what is that? Who's the first author? And I'm not a professor yet, right? I'm a struggling guy trying to make it. So Jean LeClaire, medical technologist, is the first author on this. Jerry Durbin, an infectious disease fellow, is the first author on the other. And these are curriculum vitae changing authorships for these people. And so that creates an atmosphere in which they want to do this, right? They want to be part of it. I'm not going to show you another one that went in the New England Journal where the first author was a nurse who was an infection control nurse. That was a chickenpox outbreak at Children's where a patient came in with transverse myelitis, got high-dose steroids, developed varicella, was put in an isolation negative pressure room, and yet we had this enormous outbreak on the ward. And even a patient way down the hall who was on precautions for salmonella got the chickenpox. And so I figured, okay, I don't know anything about this topic. We got a nurse, so the usual people to help with this. And I cold called somebody at the School of Public Health who said he was an aerobiologist. Myself and Dennis Ross-Degnan, who is an expert in interrupted time series analysis, which is a sophisticated form of time-ordered data where you can adjust for confounding variables in a very robust way, did this project. And Michelle Weinberg, who was the ID fellow, did get a small grant from the Infectious Disease Society of America that I think when all was said and done, we had $45,000. And we were going to work in 2 large safety net hospitals for the poor in Bogota. And in Bogota, in those days, was the Medellin drug cartel. And I was driven around in a armored car because the host's brother had been kidnapped by the cartel, and so everybody was on edge. You couldn't go anywhere without an armed it was like going these days to Yemen or something. Not quite, but it was not good. And these are people who decided they wanted to do something about it. So do we send them off to IHI for 5 weeks of training in improvement science, or no? We have a problem in front of us. We're going to do just-in-time training, and we're not going to use fancy words. So this is a Ishigawa chart. Even a fishbone diagram. It's a cause and effect diagram. We sat around like this, and again, we did it over cold coffee, good cold Colombian coffee in the morning with the obstetricians and the nurses. And we said, what do you think causes these problems? And they listed a bunch of stuff, and it's basically put them up, Post-its all over, kind of looking for themes. And these are all the things they came up with. And they're basically 5 buckets of causal factors. Antibiotic prophylaxis, skin prep, surgical technique, host and antenatal factors, and then things occurring in the peripartum period. And within those buckets, there are a lot of specific things that they mention. This is their theory for what causes or doesn't or prevents surgical site infections and endometritis. And it's pretty basic epidemiology, really, but based on their experience and to some extent on their knowledge of the evidence. Then they questioned me. They said, well, how do we know the antibiotic prophylaxis really works? We don't know that literature. And I had brought with me all the meta-analyses of antibiotic prophylaxis and cesarean delivery. So you have to have in your pocket all the evidence you might need to counter somebody who's a skeptic. And so I pulled this out of my pocket and said, all you need to know about this statistical method is if it's less than 1.0, it's protective. And those little bars, if they don't cross 1, means it's statistically significant. And then I explained it. Anybody wants to know about confidence intervals, I explained it. Anybody looking at this would have no trouble seeing, no matter how many studies have been done, they show antibiotic prophylaxis is really, really effective and should be the standard of care. So then we did a priority matrix. They had to decide what to work on. Has anybody ever done a priority matrix? Most people, most audiences, one person may raise their hand. This is a crude priority matrix. Basically, you list your important factors. In this case, there were the buckets, the 5 buckets of causal things. And then across the top, you put the way you're going to prioritize stuff. And I've really simplified this, but is it important? So they thought almost all of these things were pretty important. But is it within the capacity of us as residents or in our hospital to improve it? And they said, oh, the antenatal factors, they live in a barrio, we don't go out there, that's going to take, we can't really control that. And the same for peripartum events that weren't related to labor and delivery. And so they got lower point score. And then are we going to be able to do this in a reasonable time frame or not within my residency or fellowship? And the answer for some of these was, oh my God, it'll take us forever to get and you can get the idea here. And there was also one for money, and there were about 5 of these columns. And they said, all right, let's work on antibiotic prophylaxis. We believe your data, Don. You brought us all those meta-analyses. We ought to be able to do that. So what's the first thing we would do after we said, okay, we have a causal theory, right? We have some evidence. We have done a priority thing. So what do you do next when you got people over their cold Columbia coffee at 5 in the morning? You want to understand the system of care, right? Does that make sense? You want to understand, well, all right, what is the process for getting antibiotics into the woman at the right time? Okay? So they said, all right, well, before we look at that, why don't we look at our own performance? I said, good idea. And what's the usual thing you hear? You hear, well, we don't have the time to do it. We have to establish a database. It's going to take 6 months. We have to, literally, people will say 100 charts. So I'll just give you an anecdote before I show you these data. We had an attempt to get our asthma folks to give out asthma management plans. And so we have primary care clinic, right? We have an asthma immunology clinic. We have a pulmonary clinic. And then we have the adolescent service, and they're all taking care of asthma patients. The pulmonary people said, oh, we're doing great. And I said, well, why don't we find out? They said, well, we can't take the time. We don't have a database. So I went up to the ward and I said, let's take 10 charts off that pile and see how many people got asthma management plan. And one had gotten an asthma management plan. That's the end of that debate, right? So most of these data can be collected. And within a day, they collected these data. So in hospital A, 70% were getting antibiotics at all, and they weren't getting it on time. In hospital B, they were a little bit better about giving it on time, but they didn't give it very often. And I don't remember how many charts. They were the charts that were lying about from that week that we looked at. We didn't have computers, didn't have a database. That's all you need to know to get started. And here's the system diagram. So in hospital A, you plan to perform a cesarean delivery, and then you ask the question, am I going to order antibiotic prophylaxis? And since you don't know the evidence yet in this old system, the answer might be no. If the answer was yes, the order went to the pharmacy. The pharmacy has another decision node, that diamond. Do we have the antibiotic on stock? And it turns out that the surgeons all had different antibiotics that they like to use. One of them had gotten them from Eli Lilly's, some fancy new antibiotic. Another one wanted to use the cheapest thing. But there was a whole variety of orders that came to the pharmacy. This is a poor hospital. They can't stock all those antibiotics. So if the order could not be filled, this is Colombia, they gave the family a new order, and they went outside of the hospital to vans that are parked there and bought the antibiotic and then brought it back to the hospital to be given to the mother. And you can imagine that's not a very efficient system to get it there at the right time. So we had them revise the system, and this took quite a while. There were many tests about what might work. But basically, a standing order was written. I remembered what we'd done with Jerry Durbin way back when with standing orders. If you didn't want to give the antibiotic, you had to give a reason why. The default was to give an antibiotic. There were only two, clindamycin and Kefzol, both generic, both actually quite cheap. The antibiotics were not sent from the pharmacy. They were put right from labor and delivery into the OR packet, went to the OR with the mother, and were administered at the right time, theoretically. And this took more. We weren't sitting there for this whole project. We were back. By the way, in the wintertime in Bogota, if you ever get invited, it is cold and it rains. And we stayed in a cheap place where the roof leaked. And so to get to the shower, I had to go through this leaking curtain, and I would get hot in the shower and then jump into my bed damp still and hope that I'd stay warm for the night. So you have to make sacrifices. This is a interrupted time series, and I'm not going to tell you what period 1, 2, 3 and all that is. I just show you the results. These open circles are giving the antibiotic, and that turned out with this new system and the standing orders to get reliable up to 90% very, very quickly. And eventually got up to near 100%. Getting the timing right was a little bit more difficult, getting the packets and all that. There were a lot of tests, and it took quite a while to get that done. And the infection rate, which is these black diamonds, fell by, I think it was 2.5-fold over the course of this, pretty nicely associated with the improvement in the giving of the antibiotics. As it happened, because they were more vigilant now and more involved in QI, they also improved the incision they made. There's something called a steel or whatever that's this way instead of this way, and at least it's fewer infections. They changed their surgical prep. They stopped doing so many vaginal exams. They improved a lot of stuff. And so this got published in the Archives of Internal Medicine, and Michelle was the first author. I'm just going to give one more if I can, and then we'll quit. Is that all right? Unless you, this isn't the kind of thing where you're going to have a lot of questions. But I do want to show you this random safety audit. Now, I know you spend a lot of time worrying about reporting your errors. And as far as I know, there's no evidence that that is helpful. I mean, it's nice. Glad you do it. But of all the things you can do, it's probably not one of the more effective things. But keep doing it. You have mortality and more conferences, and that's great. And I'm sure the data from there goes somewhere, and somebody acts on it. You can use the IHI Global Trigger Tool, which takes 20 minutes for chart and will drive you crazy. But it's a nice, valid tool for finding harm. You can do automated data mining, which is okay for some harms, like hypoglycemia. That's not hard. You get that off the lab system. But it's a lot harder for things like pressure ulcers, which aren't well coded. Or you could do a random safety audit. So what is that? This is Paul Plesick, who's a great innovator, was sitting around having wine with me one night, and he said, you know, there's something in banking called the random audit. And now this is all pretty much automated, but back when we were thinking about this, there were some audits that were still done by hand, and they were done randomly because they couldn't do them all every single time. And he said, well, maybe we can do this kind of real-time, rapid audit at the front line, and then we'll have the data immediately so the team can see it. And then all kinds of good things happen. So everybody's there. It's a peer process. It's interprofessional. This actually sounds like good behavior change there. In fact, what are the elements of a good behavior change? You have to be enabled. You have to have self-efficacy that you can do something. Peer norms are very important. We could go on with that, but it's actually sound from a behavioral point of view. So it really combines audit and feedback, looking in real time at how people are performing, with the chance to do immediate experiments or PDSA cycles. So that's even more rapid than let's see what we can do next Tuesday. It's what can we do today? We had a Delphi thing with neonatologists all over the country. This was to be done in neonatal ICUs. They came up with 20, whatever it was, safety issues that they agreed were important. And we made a deck of cards, literally, that were about this big. One side of the card was trivia, so where does Don like to eat his sushi? Would be a typical thing, just as an icebreaker every day. And on the other side was a simple data form with a space for every single bed space or neonatal ICU space. And the answer is either it was done or not done or it was not applicable. Those are the only answers. And you go around with this thing and you pick randomly out of the deck, and today you may pick hand hygiene, tomorrow you might pick oxygen monitoring settings, the next day you may say specimen loss, the next day it may be had to repeat an x-ray because whatever. And you can imagine what those 20 things might be. And so on first week, if I'm not mistaken, we're going around and we pulled O2 sat monitor, the O2 alarm settings. And wow, about half of them were wrong. In fact, most of them were too high, and retinopathy prematurity is no laughing matter. Why were they too high? Some nurse had been told by some doctor that that's where they ought to be, and it became the thing they did, and it was systematically wrong, and we could correct that the same day and potentially reduce harm. So that's pretty impressive. We actually had outside secret monitors checked to make sure that people were not lying. People don't lie in peer situations. I mean, maybe if they're a cult or something, they lie, like Scientologists will lie maybe to each other, I don't know. But in general, health professionals are not in the habit of lying to each other as a group. So, and there was good validation that, in fact, almost all of the things that should have been noted were noted and noted correctly. Very high fidelity to the rules. 84% participated in a round where this was done. 100% agreed or strongly agreed that it improved quality and safety, which is amazing. And almost all of them said it really increased their knowledge of clinical guidelines and safe practice. And only 9% said it added to their work. So, and by the way, it got published, and the main authors were a neonatologist, a nurse, the same drill. So there's another project which cost no money, which was integrating research, really, into routine work. And I think that's the secret. If you can't collect the data you need as part of your real improvement work, rigorous improvement work, in the system you have, rather than saying we can't, we need to hire get a student, volunteer, hire a nurse, ask yourself, maybe my system needs to be redesigned so I can actually capture the data that matter to making my care as good as it can be. And almost always you'll find that there's a way to do that. The reason the CLABSI is such an easy thing to do is if it's done right, the checklist is the record. It's not some extraneous piece of paper. It's integrated into the flow of work in real time. The people who are responsible for the activity are at the bedside, and checking the boxes is the record. And that's why it works so well. It's really simple to incorporate. So I would use that as a principle. So there's a paper, and you'll have the slides, but there are 10 tips that I've written about to doing this and getting it published without a lot of federal grants. But it all boils down to curiosity and generosity from my point of view. People in general who are working in other professions are curious about what doctors do or what quality improvement people do. And if you bring them in, they'll almost always be happy to learn more. There's a lot of behavioral psych stuff that says paying somebody $1 more is not nearly as effective as having them learn something on the job every day. It's just really well known. So that's number one. And number two, be really generous with the authorships. Make it your business to say, okay, Jean LeClaire, okay, Emily Reinhardt, okay, Bill Durbin, you have done the work. You've contributed, every one of the checks on the authorship form, you've contributed. Maybe you don't know the statistical analysis, but this work would not have been possible without not only your intelligence about the work, but without your hard work. And give them the first authorship. Even now, if you're in a point in your career where you need that first authorship, most schools, including Harvard, will allow you to asterisk a second authorship and explain that you had a mentee, a student, or whatever, who you put in this position because of the work they did as a mentee. And that counts as a first authorship. And when you get a little older, you can make yourself the senior author and take yourself off of that as fast as you can so somebody else can get the benefit of being a senior author. So I think those principles actually work. They work for me. My CV is what it is, and I am where I am because somebody counseled me at some point in my life that it was important to involve other people and give them the credit they deserve. So I really encourage that. So that's it. You're on your way. Good.